we're going to round out our afternoon. There's been talk of immunotherapies. Everyone's excited about immunotherapies, and Dr. Sborov is going to update us on trials that are in progress in this space and some things that we can be watching for. Dr. Sborov.
Thanks. You know, you shouldn't brag. 6, was it 5 or 6 bone marrow biopsies? 5. I mean, because how many times have I been asked that? Well, you do the bone marrow biopsy, right? I should probably do one. If there's a study, I'm saying it today, if there's a study, I will do a bone marrow biopsy. You know? What's that? Without sedation, just lidocaine. Because we don't need sedation, right? You don't need to go to IR. You know,
that's why we want you to try it first.
I think that, you know, when you think about what we do, it's just so medieval, right? And I think that we have to go to the source, as we just saw. We have to go to the source to be able to get the biopsies to understand what we're dealing with. And, you know, this is a whole nother topic, but really these tests looking at the peripheral blood and looking at circulating tumor plasma cells and that work is fascinating. And the hope is that in time, we don't have to say, hey, you have to do a bone marrow biopsy. We can just take some blood. But we're hematologists, so we're vampires. So we love to take blood. Anyway, you know, myeloma doctors are competitive. I'll say it's really an honor to be in the room with you and sharing the stage with you. I think that you know, you fundamentally changed how we think about imaging in myeloma patients, and I think that that's our goal. All of us in myeloma are, and all of you guys, we're all just here to try to make a difference. And it's really incredible how much you've been able to do in a short period of time. So. We'll get to this. I'm going to run a little short as well because I think it's going to balance out to be about a total of an hour for both of the talks. But I named this talk "Persistence Beats Resistance," based on a text message exchange I had with Jenny. You know, as we move forward, we're not going to stop. Right? We're all going. It's all guns blazing. And this sort of goes, persistence beats resistance of growing a myeloma program or, you know, working on cure, right? Or finding drugs that will treat those resistant plasma cells so we can actually get to where we want to be. So persistence beats resistance, the best advice I ever got. And I like it as a title of this talk. So I'm just going to review some of the trials that are ongoing and some that are upcoming in myeloma. There's probably going to be a lot of tables, and so if I see people falling asleep, I'll tell a bad joke. I don't know why it's... There we go. My disclosures again. All right, so I showed this slide, some form of it in the first talk. So again, the basic way we approach myeloma, it's likely not going to change anytime soon, but it eventually will. And we've got the monoclonal antibodies, the bispecific CAR-Ts, ADCs, everything else. They're being investigated in all phases of myeloma. And so you guys are probably aware of this, but how these drug development things work is that you start in late line setting, in the phase 1 setting, and once you show that it's safe and maybe has an efficacy signal, then you start moving it up. And so the bispecifics are now in 1 to 3 prior lines. They're moving into the newly diagnosed space. And so that's how things move in our world. So right now, 2022, first-line algorithms for the transplant-eligible patients, we treat with triplet or quad-based induction, depending on if you believe the Griffin data, followed by transplant, followed by either Revlimid or doublet. Risk-adapted maintenance, and I'm not going to say it this time, not indefinite, but most of the time we treat further. And then in transplant-ineligible, we have indefinite triplet therapy based on the Maya trial, looking at daratumumab, Revlimid, dexamethasone. So I was trying to think about how I could put on a piece of paper a couple of the thoughts that I have about where we might be going. All right, so how do I envision the next step towards cure? And so I put this together. And I had a couple of my friends in myeloma look at it, and they're like, yeah, this seems pretty reasonable. So what I think is going to happen in the next couple of years, this is one idea. So in the transplant-eligible space, we're going to utilize a monoclonal antibody-based 3 or 4 drug therapy, most likely a quad, or a non-BCMA bispecific as a triplet or a quad. Couple of cycles of treatment, get some disease control, clear the marrow out a little bit, hook you up to a machine, get some CD34 positive stem cells, and get the T-cell product. Put both of those in a cryofreezer, because both are very important. The stem cells not only for autologous transplantation, but also potentially for rescue if the marrow gets too beat up in the future. Following that, try to get a little bit deeper, sort of like a modified consolidation therapy. So using the same drugs that we use for those first few cycles before collection, use them again, then assess where you are. And so this is where you have one of 3 different directions you can go. So if you're stringent complete response, MRD negative, maybe we can skip CAR T, maybe we can skip transplant. Maybe we can just move on and keep some therapy going. That therapy would probably be risk and MRD adapted. Maybe we'll throw in a cell mod at that point because we think a drug like iberdomide might be a little bit better tolerated than Revlimid. We go to the top, and if you're not in a very good partial response or have high-risk disease, that is, if you still have disease present or have disease that we know is inherently more resistant to our currently available drugs, maybe we consolidate you with a transplant. We know that melphalan is good. It's a very effective anti-myeloma therapy, but it's toxic, right? So this arm is sort of like, well, listen, you've got bad disease, and we've got to give you all the drugs we can possibly give you. So why don't we try an auto? And then from there, we would say, well, maybe you're MRD negative after your autologous transplant. Let's move on. But maybe you still have disease. You still have disease after transplant, after all these novel triplet or quadruplets up front. I'm thinking that your disease might be pretty resistant. So at that point, maybe I want to bring in a CAR. We know the CAR's pretty good. And then we have everybody else. Maybe we can skip transplant for now. Maybe we can just go to a CAR T therapy. And then across the board, I do think that we need long-term maintenance therapy, at least based on the data that we have available now. So that was the idea that I came up with. I'm sure that there's about 2 billion holes that we could poke in that idea. But I think that the concept here brings up a couple interesting points. One, bispecifics are maybe moving up front. Right? We're moving towards quad therapies. Griffin trial, we'll go through a couple of these. I do believe that we should be collecting both stem cells and T cells if we can. I think there's a question of whether or not cryopreservation of the PBMCs or the T cells will allow them to be effective for making CAR T in the future. Another idea here is, well, what's the role of transplant? Everybody's asking that. For those of you who've been through an autologous transplant, those are not very fun weeks, even if you can spend it outpatient. Then we talked about second primary malignancies. Well, exposure to melphalan and IMiDs can increase the risk of second primary malignancies. So if we're keeping you guys alive longer, that becomes even more real. We don't just see skin cancers, we see hematologic malignancies, MDS, ALL, AML. So there's a lot of debated concepts that are in that transplant ineligible space, but the idea here is that we're thinking about it and thinking about ways to get around it, and the idea is to utilize our better drugs up front, as I was saying before, to see if we can get long-term disease control, potentially cure. So in the transplant ineligible space, I think a BCMA bispecific plus daratumumab. I think that's pretty realistic. It's coming up. And so I don't know what that space is going to look like, but my hope is that we can get a very effective, well-tolerated triplet regimen that can get patients' disease under control and keep them there, and hopefully not on drug for a long period of time. The question is, how do we get there? Okay, so here we are. So we've got neo-total therapy. I haven't seen all the lectures today, and I apologize for that, but there's a mention of Dr. Barloghi and total therapy. This program here at the Huntsman used to be a total therapy program, which is you got a bunch of drugs that can work against myeloma, so put them all together and beat people up a little bit, put them through a couple of transplants, and we move on, right? The idea there is use the best drugs you have to get long-term disease control. So neo-total therapy is, daratumumab's good, let's add it to 3 drugs that are pretty good, right? So we have all of our triplets. We've got VRD, KRD, so Velcade, Revlimid, dexamethasone, carfilzomib, Revlimid, dexamethasone. And then we've got daratumumab, Revlimid, dexamethasone, based on the Maya trial, S0777, Forte, Endurance, all these very, very important trials in the field. And then we have our quads. And so we've got the Griffin trial, and we are presenting the final analysis in LA next month, which would be very exciting. We'll talk about some of the problems with the Griffin trial, but we have Perseus behind it, and Perseus is going to definitively answer the question of quad versus triplet, at least with this regimen. We have the Master trial. It was written by Dr. Costa down in Alabama. It was awesome. Great trial. I'm going to say a few things about that. We have Advance that I know that Roswell Park and our group is working on with Dr. Langren down in Miami. Then we have the GMMG HD7 trial. And then there's some of us who use daratumumab Cybor-D, especially in those patients that have renal insufficiency or renal failure, especially at the time of diagnosis. So let's move into why we're thinking about quads. So this is a Griffin, phase 2, about 200 patients, looked at daratumumab, Velcade, Revlimid, dexamethasone, followed by transplant, followed by similar regimen as consolidation, followed by daratumumab and Revlimid maintenance. In one arm, the other arm was VRD, followed by transplant, followed by VRD, and then Revlimid. A little bit bigger for you than they are for me, but what we know is that there's about a 99% overall response rate in the quad, which was higher than what we saw in the triplet. We know that over time, patients had deepened responses in both arms, really. But we know that the quad led to a CR better rate in about 80% of patients. And then we talked about MRD negativity, and you can see that the 12-month rate of sustained MRD negativity with the quad outperformed that in the triplet. And now we're starting to see at a 38.6-month follow-up that the PFS curves are starting to separate. So one of the problems with this trial is this was one of the first stabs at the quad. So we had Cassiopeia trial that was being done in Europe, but this is the first that was looking at the quad here in the States. And so they didn't know if it was going to work. We had basically a pilot or a run-in portion of the trial to see if this was going to be safe, and that showed it to be safe. And so we moved on to the trial. But the primary endpoint of the trial is stringent complete response after consolidation. Okay, so when we're thinking about randomized phase 3 trials, we're talking about survival endpoints, like progression-free survival, okay? And so one of the big conversations in the field is, well, this trial wasn't powered for PFS, and so can we really believe it? And so there's 2 camps right now, either the triplet camp or the quad camp. And I think and then there's a lot of us who are sort of in between, okay? Now, Perseus is a very similar trial design, but it's looking at sub-Q daratumumab rather than IV, and is powered for progression-free survival. So that will be the definitive trial for this space. So another quad. So let's throw out Velcade and let's throw in carfilzomib. We know that Velcade causes a bunch of peripheral neuropathy. We know that carfilzomib can cause some cardiopulmonary toxicity as well as some renal insufficiency. When we look at carfilzomib and KRD versus VRD in our trials, we think that they're pretty equivalent. And so There's some of us who think that DARA-KRD is very effective and can be very effective even in patients with high-risk disease, and this MASTER trial is really a neat effort for a lot of different reasons, but one of the things I like so much about it is it shows the performance of this particular quad in patients with high-risk disease. So this is a phase 2 trial, okay? So it looked at daratumumab, KRD for 4 cycles. Patients were transplanted. They then received blocks of 4 cycles of consolidation, then followed by Revlimid maintenance. And the stars indicate the time points in which we assessed MRD negativity, okay? So if a patient achieved MRD negativity at 2 different time points, they stopped, okay? So you can see the MRD responses by phase of therapy in the figure on the right. On the top in the red is MRD at 10 to the minus 5. That was the primary endpoint. And in the blue at the bottom is 10 to the minus 6. What I want you to appreciate is by the end of MRD-directed consolidation, there's extremely high rates of MRD negativity at 10 to the minus 5 and 10 to the minus 6 in all comers, right? But now you compare the 0 HRCA, high-risk cytogenetic, 1 high-risk cytogenetic feature, and 2. You see that? You can see that those are pretty similar, right? So this regimen seems to be working in patients with high-risk disease, okay? So the PFS at 2 years for patients with high-risk cytogenetics was 58%. Not bad. Could do better, but not bad. It's a step in the right direction. So throughout this next few minutes, I'll be talking about trials that we have at the Huntsman, only because I'm not below giving myself shameless plugs, but more so that I want you guys to know what we have available out here. And this is a trial that Dr. Langren wrote, and it's initially it was looking at 3 different arms, VRD versus KRD versus DARA-KRD. And we've dropped the VRD arm, and so now this is a trial looking at KRD versus DARA-KRD. Patients get 9 cycles, have their MRD status investigated. If they're MRD positive, they go to auto transplant. If they're MRD negative, they just go to maintenance. If they were MRD negative or positive and went to transplant, then they would go on maintenance after that. Okay. I'm trying to identify some themes in these different trials that I wrapped into my one idea that I presented at the beginning. So going back to this concept that high-risk disease is that one of the holy grails, I think, of myeloma therapies. We're doing very well for most, but we're not doing great for all. And so definitely not the only one that's thinking about these patients. And we have a number of trials that are either open or are planning to be opened in the near future, investigating upfront treatment of patients with high-risk disease. So this is a trial design of the concept trial as a phase 2 trial. Patients had newly diagnosed disease, had ISS 2 or 3, with at least 1 high-risk cytogenetic feature, deletion 17p for 14, 14, 16, or more than 3 copies of 1q21. Patients received ISA or isatuximab, carfilzomib, Revlimid, dexamethasone for 6 cycles, then underwent autologous transplant if they were eligible, and then had another 4 cycles of consolidation. If they were transplant ineligible, they just received another 6 cycles of ISA-KRD, and then they received ISA-KR in maintenance. More drugs for a longer period of time. Does that work? Well, the overall response rate was 100%, so what does that tell us? Well, good drugs, got patients under control, 40% MRD negative post-induction. Pretty good, but not. I would suggest that it's not good enough. So some other trials that are down here listed, KarMMa-4, this was physician's choice of induction times 4 cycles, followed by Abecma or Ide-cel, followed by Revlimid maintenance. Optimum, which is daratumumab, Cytoxan or cyclophosphamide, Velcade, Revlimid, dexamethasone, 5-drug induction therapy plus transplant, followed by a number of cycles of consolidation, followed by 2-drug maintenance. Overall response rate, 94%, 40% MRD negative. Good, but not good enough. IFM 2018 was daratumumab KRD, or dara KRD times 4, followed by transplant, followed by more dara KRD, followed by another transplant, followed by DR maintenance. More drug for a longer period of time. Overall response rate, 96%. Okay? Starting to get the theme here, right? Last one, Blenrep or belamaf plus KRD. So we're all exploring this, and I would say that again, this is our point at new diagnosis. This is our point to really get patients under control. So how do we do better? I don't have an answer yet, unfortunately, but we're working on it. So now we're thinking about, okay, let's move the bispecifics, let's move the CAR Ts, let's move the ADCs up, see if we can get those out of the late line setting, closer to the front line. These are the trials that are looking at the immunotherapies in the upfront setting. So we have the CAR T. So I mentioned KarMMa-4. We also have CARTITUDE-5 and CARTITUDE-6. CARTITUDE-5 is VRD times 8 followed by cilta-cel versus just staying on VRD followed by Revlimid dexamethasone. CARTITUDE-6 is dara-RVD followed by transplant, followed by dara-RVD, followed by Rev, very similar to the Griffin trial, versus dara-RVD times 6, followed by cilta-cel, followed by Rev. So this is taking what we're doing now on the Griffin trial and trying to do better by throwing the CAR T-cell in. So we also have Monumental 2 and Majestic 2. These are the bispecifics, Janssen bispecifics. They are now moved in the frontline setting in cohorts of these different trials. So talquetamab plus other and teclistamab plus dara-VR or DR. And then you have the ADC. So now we're talking about bringing Blenrep up into the upfront setting. And I think the big problem with this is the ocular toxicities because, you guys can probably handle diarrhea. I know that we can try to handle diarrhea. You can probably handle fatigue. We can probably help a little bit with fatigue. Those common toxicities that you get. But if I were to tell you that, hey, listen, may not be able to drive for the next 2 months, you may tell me that that's something you're not interested in doing. But it should be explored because I think that we don't know. We don't know what the right thing is to do yet. So I think these are very legitimate trials and should be considered. So as Dr. Shah talked about, is the idea of exploring MRD negativity. So we have the MIDAS trial, MASTER-2 trials coming up. And I do sincerely apologize. I this week got a little bit too busy at the hospital, and so I wasn't able to put the trial design together for MASTER. But I think that it's going to be a trial that everybody should be watching out for. I think that it's innovative, and there's some really good ideas embedded in it. And so please keep your eyes open for that. So maintenance. I know we heard about the dramatic trial. So this is that again. If I would have shared slides with Dr. Shah, I would have known that she was going to talk about this. But I think that the table below is very important. And I think that this is a very exciting area of our field because I think it's allowing us to bring these drugs closer to the frontline setting and help us understand how they're going to behave. Not in just the near term, but the long term. So we have elranatamab, again, that's Pfizer's bispecific versus lenalidomide. We have Blenrep plus lenalidomide. We have Tec plus Rev versus Rev alone. That's Majestic 4. And then a trial that we're a part of, which is ARIGA, is looking at daratumumab versus daratumumab plus lenalidomide in patients who are MRD positive. And that trial is actually finishing up in hopefully the next couple of months. It'll be interesting to see what that looks like. So optimizing our currently available immunotherapies and identifying next generation therapeutics. All right, this is the dream platform. So you're a drug company and you're like, hey, I got a new drug. Looks pretty good. Let's put it with everything that we can possibly imagine in every setting we can possibly think of. And so you get these platforms. So Algonquin is a really interesting trial. It's run up in Canada. That's Blenrep plus pomalidomide. The results are actually very impressive. And they've done a nice job at trying to figure out appropriate dosing. So that's looking at Blenrep every 8 weeks, and it looks like patients are tolerating that to touch better, even though the rates of grade 3 or higher keratopathy and blurry vision are similar to what we saw in DREAM 2. We're working on that, but the median PFS is 17 months in patients who have been treated with at least one prior therapy. We've used this regimen a number of times in our patients, and they've done quite well. Looking at Blenrep plus the PD-1 inhibitor pembrolizumab, that was recently presented. Looking at DREAM 5, Blenrep plus, I can never say this word correctly, it's a GCI inhibitor, GSI inhibitor, basically decreasing the amount of BCMA that's floating around in the blood. And so the idea there is increasing the targets on the myeloma cells. So you can see that the overall response there was 60%. Still early, not many patients. Looking at Blenrep plus Revlimid dexamethasone with VRD, et cetera, et cetera. I think that the DREAM platform, the most important trial in the DREAM platform is DREAM 14, and that's looking at different regimens, so different ways of treating our patients, different dosing frequencies and different doses themselves. Because I think that this drug has a future. We just have to figure out how to best use it. So this is a sampling of the next generation bispecific trials. Majestic 3 we just opened. It's going to be open for a very short period of time because everybody's very excited about it. This is looking at teclistamab plus daratumumab versus standard of care, daratumumab, pomalidomide, dexamethasone, or DVD in 1 to 3 prior lines of therapy. This is most likely going to be practice changing. There's the 1B looking at teclistamab plus talquetamab. So if one bispecific is good, why not add a second to it with a different target? And then you have the teclistamab combined with any host of different drugs. They were able to throw that into one trial, which is pretty impressive. And then you have Monumental 2 looking at talquetamab plus all these different drugs. You have the magnetism platform. So elranatamab is looking to be a very attractive drug. I talked about the maintenance trial, but we're also trying to understand what drugs to pair with it and how we should be dosing it. So we're part of the Magnetism 9 trial, which is a great opportunity for our program, looking at alternative dosing. So we're trying to push the dose of elranatamab up. We're trying to figure out if we can space the treatments out from weekly to every other week to monthly, so that patients aren't on a bispecific once a week for a couple of years. Sorry, I can't find you. You're somewhere in this room. And so, I think that one of the things that we worry about with these bispecifics is atypical infections. And when we are hammering on the immune system for many, many months, potentially many years at a time, we have to be worrying about the potential long-term toxicities, and infections will be a very real part of that story. Selected novel CAR constructs. So what's important to know here? We've got some CARs that are coming right now that are as good, if not better, than anything we've seen. I think that we're very, very early in the development of bispecifics and CAR T cells. There's a lot of things we don't know. What's the best target? Okay. What's the best transduction mechanism? Should we be using maintenance therapy? What setting should we be using it in? There's all sorts of different questions that we're asking, and this is just a small sampling, but you can look at the last three lines there. You can see that in heavily pretreated patients, you're seeing very high overall response rates and very high rates of MRD negativity. This is small patient populations, but we're getting better. We're getting a lot better. But it's going to take some time before we really figure these things out. Now, CAR Ts, there's a million different ways that technology is going to change. We're likely going to be able to turn it on and off, also known as driving the car, right? We're going to figure out ways to potentially immune therapies that we can use as maintenance to re-stimulate the expansion of the CAR Ts. I mean, it's almost endless, the technology that we're looking at in this space. So we're still early. I think we're in the ice ages of CAR T therapy. So again, shameless plugs. We're opening the magrolimab trial. Magrolimab is an anti-CD47 monoclonal antibody. You can see from the picture on the left there that, so we have these cells that are called macrophages, and macrophages are generally, their job is to clear out bad cells, in this case tumor cells. And so you have a macrophage, which is in blue, and then you have the cancer cell, which is looking mean in the gray. And what this drug does, or sorry, what the cancer cell is able to do, and why myeloma and so many other cancers are so good at staying alive, is that they throw up these signals, right? They say the immune system passes by, and the cancer cell says, well, keep going. I'm a normal cell. Yeah, don't worry about me, right? And so, so what this is basically they throw up, the myeloma cell throws up this "don't eat me" signal, okay? And so by blocking that signal with this particular antibody, the macrophage can see that it's actually a cancer cell and it's going to get rid of it. At least that's what it is in theory. This drug has not been looked at in multiple myeloma. This is a phase 1b trial that's opening, but we have seen magrolimab be used in a number of different malignancies. So this trial opens next week. We're putting the first patients on this trial, first myeloma patients on this trial anywhere, and we're really excited to see how this behaves. A couple of things you should know about magrolimab, because many of you may come across this drug. It does cause anemia, so you get the drug and it drops your hemoglobin down 1.5 points or 2 points. You can stay on the drug and your anemia will likely persist, but it will not get worse. It's also associated with infusion reactions, just like all of our other monoclonal antibodies. So TAK-573 is a drug that's really making its move. We've been fortunate enough to get over some of our difficulties with the company, and we're able to open TAK-573 now. So I'm going to be very excited to use this in patients for the first time. And basically what this is it's a souped-up Ferrari daratumumab, or monoclonal CD38 monoclonal antibody. Basically what this does, it has a little signal, so once this thing binds to a myeloma cell, there's a little signal that's thrown out that says, hey, immune cells, come on over. So it calls over both the innate and the adaptive immune system and can kill the myeloma cells directly. We do have early data from this drug. You can see that in all patients on the right side, all patients that were treated had an overall response rate of 40%. And you can see that some of the toxicities that are listed there on the left side. So this is a neat modification of the idea of a monoclonal antibody, and there'll be many more of these types of modifications to come. So again, shameless plug. I'm going to tell you all about what we're trying to do. And so for those of you who live outside of the Salt Lake area, which I think is most of you, probably can be done listening at this point, but what we've been able to grow here at the Huntsman, I'm really proud of, and I think it's worth bragging about. I think that what we're doing, and what we've been able to do, is to bring clinical trials to the Intermountain West, and we've been able to grow our clinical trials office to be able to perform at a high level on these clinical trials. And we have patients here that are very engaged, just like all of you guys. Our patients are excited to go on clinical trials, and it allows this program to continue to grow. As it grows, we're able to bring more and more of these new drugs here. So we have trials in high-risk smoldering myeloma, which is the DTER smoldering trial. We have 3 trials in the newly diagnosed space. I already mentioned advanced, but there's a ECOG trial called EQUATE, as well as investigating iberdomide in combination therapies. We have an auto transplant investigator-initiated trial. My partner, Dr. Mani Mohyuddin, is opening a trial looking at budesonide as basically a prophylaxis for diarrhea and other GI toxicities during auto transplant. We have the 2 maintenance trials, Ariga, SWOG, S1803. We have 4 of the different bispecifics, which is fantastic. We've got the magrolimab TAK-573 coming. We have LumaCAR-2, which is looking at the CAR-T CT053. We have ARC-112, which is looking at DDBCMA. Then we have a couple of trials that are focused on 11-14 patients. And then I have a trial that's currently open looking at disulfiram, also known as antabuse, a drug that's being used for patients who are alcoholics. It's an alcohol diversion therapy. And when we combine it with copper, it turns out that it has anti-myeloma activity. So that's a pretty cool thing. And we have a couple of homegrown trials or homegrown drugs that we're bringing out of the lab for our patients in the phase 1 setting. So it's a very exciting time for us. And with that, I want to thank you for your time, and I think we have some time to answer some questions. So.
Oh, wow. In my opinion, there's no one better to break down the clinical trial space than Dr. Sborov, and I am in complete awe with what he's done to grow the clinical trial program at Huntsman, and the growth that it's seen under his leadership has just been phenomenal. And you can see that, and I'm grateful for the persistence from Dr. Sborov, Dr. Hillengast, Dr. Shaw, and all myeloma researchers, and their persistence against resistance in bringing that hope that Dr. Sborov talked about this morning to all myeloma patients. So I just want to give them a deep thank you from all of us.